Beach Radio 1160 and 1310 and MyBeachRadio.com proudly present Painless with Dr. Gabriele Jasper of the Jasper Spine Institute. On this show, Dr. Jasper will discuss new innovative techniques to get rid of pain while avoiding unnecessary spine surgeries. Here's your host, Dr. Gabriele Jasper.
Good morning, Dr. Gabriele Jasper, just to be a little redundant, MD, interventional pain physician from Brick, New Jersey, 74 Brick Boulevard. My number is 732-262-0700. You know, as I start this show every day, or not every day, every Saturday, I like to talk about a little bit of what I do overall. And I'm the type of pain doctor. I'm not just a regular pain doctor. Number one, I don't prescribe narcotics. That's my main thing. You know, if I do a minimally invasive spine surgery on somebody that I inflict pain on them, I'll give them a little bit of narcotics. So I'm capable of doing it, but I have a couple of major philosophies that I stand by. Number one, no narcotics. I guess if Chris Christie was listening to this, he might like me. Number two, no major spine surgery, no major unnecessary spine surgery. I mean, sometimes you need to have it, but let me be the decision for that. So what do I do? Let's start with the basic, what does an interventional pain physician do, or a pain physician? We treat sciatica pain caused from herniated discs. Sciatica pain caused from bone spurs touching the nerve. What is sciatica pain? It's pain, a nerve getting pinched by something. I treat back pain from arthritis of the spine, back pain from compression fractures if somebody breaks their back. Oh, by the way, I want to put something in here. If anybody has any questions about any of these things I'm saying, you can interrupt me. 732-505-1160. Going back to what I do. Leg pain. Sometimes back pain comes along with leg pain or vice versa. And that's your sciatica pain. Sometimes your legs can get weak. You can have numbness and tingling in the feet, in the lower legs, going down your legs. That's all from the same thing, a pinched nerve. It's simulating as if when you hit your funny bone or you're leaning on your funny bone in your elbow, which is the ulnar nerve, you know, it tingles up your arm into your pinky finger. That's the same thing. It's sciatica, basically, of your arm, you know, but it's not the sciatica nerve. I also treat neck pain, arm pain with the numbness and tingling. You know, a classical case if somebody has a spinal stenosis or a pinched nerve in the neck is they pick up something and they feel weakness in their hands. Their hands aren't as strong. It's hard to open up a jar. Sometimes somebody told me that their coffee cup would slip out of their hand. That's not good. So that's basically what I do. These are all the stuff that everybody does, but there's a little bit something different than compared to the other pain doctors with me. I'm the true interventional pain physician. Some people call me the minimally invasive spine surgery or the endoscopic spine surgery. I teach all over the world on how to do this specific endoscopic surgery, and that's, you know, I just make a little teeny incision. This is one of those same-day surgeries, no general anesthesia. You got a herniated disc. I make a little incision. I put an endoscope in. It's similar to the scope that they put in for arthroscopy of the shoulder or the knee, but it's modified for the spine. It's got high-definition monitors that you can see something in the spine that's maybe less than a half an inch big, and you're looking at it on a high-definition monitor. It's like a foot long. You know, it's amplified, so it's direct visualization and very detailed visualization. Makes it easy and safe. I just go in there, take the bone spurs down, take out the herniated disc, and the pain. It's not a miracle. You know, it's not rocket science. The pain's gone, you know, because something pinching the nerve and you take it out. Another thing that we talk about every time, this is probably one of the most successful things that we've been doing lately for our patients, and patients love it. They call in all the time. I see the patients post-operatively, and it's a 10-15 minute procedure where if somebody has severe spinal stenosis, moderate to severe spinal stenosis, we open up the center canal with a little spacer. It's called Vertiflex. You can look it up online. and you'll see how we can do that. Or come in if you suffer from the spinal stenosis, which I'm going to go over real quick, your symptoms, and that's symptoms of you're not able to walk far. When you walk, your legs get weak. You get some aching pain in the lower back into your hips, and your legs start to get wobbly, and you have to find a place to sit down. As soon as you sit down, boom, it goes away. You wait a couple minutes, you get up and you continue to walk the same distance that you did before. The same cycle starts. You can't walk, you got to sit down. Sit down, you can get up again. If anybody has that, give us a call at 732-262-0700. There's another thing that's relatively new, and the company sent me out to Texas to learn how to do this. It's called dorsal root ganglion. It's similar to a spinal cord stimulator, which goes into the spine, and it kind of tricks the body. It turns your pain into a warm tingling sensation, or it can actually get rid of the pain. Now, people who have diabetic neuropathy, most people can't control it, especially if you go years without good control of your blood sugar levels. If you don't have good control of your blood sugar levels, you start to get these weird pains in your feet. It's a burning pain, aching pain. It just doesn't go away. They have different medications like Neurontin they put patients on. They put them on Lyrica. And they do pretty good, but you have some patients, no matter what you do, not even heavy doses of narcotics will get rid of that pain. They have it constant. This is where this dorsal root ganglion, it's kind of a spinal cord stimulator, but it isn't. It goes into the spine, and we find a nerve. I find a nerve that actually goes to your feet. And I put this little stimulator on what they call the dorsal root ganglion. It's kind of a swollen area of the nerve that comes out. They call that the brain or the computer center of the nerve. And you turn this little stimulation on, and it modulates that dorsal root ganglion to where the pain goes away. You know, what's great about it is you can have a trial first. You put it in right through the skin. It takes about 10, 15 minutes to do. Tape it in. You go home for anywhere from 3 days to a week, and you test it. You got a technician that stays with you constantly on the phone. You have a controller, a remote controlled non-wireless controller, where you can increase the intensity, decrease the intensity, turn it off, turn it on. And once you finish that trial period, and if you love it, then I put it into more of a permanent place. In other words, I put it all under the skin so you can bathe with it, take showers, go into the swimming pool, go into the ocean. It's as if it's not even there. Like somebody would have a pacemaker. You don't know it's there, so unless they tell you. So that's a fantastic. I've done a few of those recently, and patients that have had diabetic neuropathy for years, and it's not just diabetic neuropathy. It's a pain. For example, some people have pain that you just can't get rid of post-op spine surgery. It usually works better the dorsal root ganglion when it's a peripheral type nerves. For example, in the feet or the leg, one side, one leg, you just can't get rid of them. I don't put a lot of them in the old days because I get rid of the pain through my endoscopic spine surgery. So it's rare that I would put these in, but it's very simple to put in. And most of the people have had surgery and the scar tissue, and there's just nothing you can do about it. Don't forget, you can call in at 732-505-1160, same as it is on your dial. And we have Jeremy here today. How you doing, Jeremy?
How you doing, Doc?
Good. Jeremy wanted me to talk a little bit about compression fractures. In fact, I just got called on the way down here to go to Jersey Shore Medical Center. There's a patient in that fell, an elderly patient that fell. She has a severe compression fracture, and those are one of the most painful things you can have. Most ladies get it, that postmenopausal, the older ladies with osteoporosis, you don't have to fall much. You just lift something up heavy, and when you lift it heavy, it can crack your back, and severe pain, and I can fix it. I can fix that with a minor procedure. It's another one. I think it takes me 6 minutes average of doing it. And the patient gets off the table 99% of the time pain-free.
Well, what's the name of the procedure?
Well, the procedure is kyphoplasty. They also have vertebroplasty, but kyphoplasty is better. What we do is we go in there, create a little void in the vertebral body that's cracked, and then we fill it up with an epoxy. They call it cement, but it's more of epoxy. We have to mix it up, and it's a chemical reaction, and it spreads out throughout all the cracks of the bone, and it fills it up, and within minutes it gets hard, and the pain goes away. Because what's painful is the fact that you have a broken bone. You know, you break your arm, severe pain. They set it, put a cast on it, you have no more pain. So as soon as you set the bone with this epoxy, pain goes away. And it's as hard it's harder than the normal bone of this person, because
that's almost immediate.
Yeah, it's when they get off the table. You know, I mean, some people have other fractures that you don't see, so they might have some lingering pain from that post procedure, because you can't see it on the MRI because it might be just minor, but that hurts and you don't see it. But those heal up quickly. Within a week or so, those will heal up. But the major compression fractures, they take months and months and months. And if you're an older person who can't move around, they can't breathe deeply because it hurts so much, these people are at risk of collapsed lungs. They're at risk of DVTs, with deep vein thrombosis, which is an embolus that can break off and go to your lungs and kill you.
I think I actually filmed you doing one of these. I put it up on your YouTube channel. So if you go on YouTube and type in Jasper Spine Institute, you're going to see some patient testimonials, and you're also going to see some of the procedures Dr. Jasper does, including this kyphoplasty we were just talking about.
All right, so we've been going for about 15 minutes. Let's take a little break, and we'll be right back.
You're listening to Painless with Dr. Gabriele Jasper. More next on Beach Radio 1160 and 1310 and mybeachradio.com.
When I found out my jeans were made using child labor in sweatshops, I wrote a letter to the company saying, reconsider your labor practices. A few months later, I get a letter back saying, thanks for being a loyal customer, and they included a coupon for a 25% discount on their jeans. So I got smart, wrote letters every day to all the stores that carry the brand, asking them to stop supporting the companies who use child labor in sweatshops. And I just kept getting letters back, thanking me for my concerns, and more coupons for more discounts on more jeans. So I'm telling my friend about it, and she flips out, saying that between all the letters and coupons, some paper company cut down a small forest, driving off 2 indigenous tribes, hundreds of endangered animals, killing thousands of plant species, some of which may have contained vaccines for HIV, cancer, and syphilis. Meanwhile, the guys cutting down the trees are 13-year-old kids who will work night and day for months just to save up enough money to buy a pair of jeans made by child labor in sweatshops.
Saving the world isn't easy, but saving a life is. Just 1 pint of blood can save up to 3 lives. Visit bloodsaves.com to learn more. This public service announcement was brought to you by the Ad Council.
My name is Gabriele Jasper, MD. I'm from the Jasper Spine Institute. I am an interventional pain physician. We got Vinny today. His main problem was that he couldn't walk very far. He'll tell you all about it. So, Vinny, how you doing today?
I'm doing wonderful, doctor. I was finding that the power in my legs, the feeling in my legs was not where it was supposed to be. So finally I talked to Dr. Jasper, and he had told me about this new procedure that he had about putting this little spacer. So he did it. I don't remember how long it took. It wasn't long. I guess it was maybe half an hour, something like that. Believe it or not, when I got off the table to stand up for the first time, I could feel a difference in my legs. My legs felt powerful. They felt strong. The first time I walked up the stairs, I could feel the difference in my legs. I didn't have to hold on to anything. I didn't have to grab the banister. I mean, I just walked up the stairs, and it was amazing.
The Jasper Spine Institute, 74 Brick Boulevard in the Brick Pavilion. Call 732-262-0700.
Now back to Painless with Dr. Jasper on Beach Radio 1160 and 1310 and mybeachradio.com.
Back. Here we are. Back on the show. All right, what were we talking about? Look who we have here.
Hi.
How you doing?
I'm good. They're forcing me to talk even though I don't want to. I normally just sit here and, tell him when he's taking a break and what number to call and all that fun stuff. But I did have a question, so he's now
who are you?
I am Andrea. I help produce the show. And I'm the one that usually, gets all the accolades for helping you so much.
Yeah.
I don't know what the word accolade means.
We're gonna have to look that up after.
Well, I don't know what the word sciatica means. How about that? Well, I know what it means. I just don't know what it is. So that's part of my question.
Actually, a lot of people don't know what that means, right? That's what you were talking about.
Yeah.
Right.
So I hear you talk about
sciatica. You know who knows
sciatica.
what that means?
You do.
No, yeah. And the people who have sciatica.
Oh, that's true. But like you always hear it. So I was wondering, like, what do you do? So if somebody has sciatica, it almost sounds like they say, I have sciatica, and it's just kind of like, okay, and you move on. Like, I have a headache.
Well, sciatica is a layman term. In other words, it's a term that people just talk about. It's not actually a medical term, but we know what that means. You know, when I hear a patient has sciatica pain in my office, to me it's a relief, because sciatica pain is one of the most easiest things that I can get rid of. And sciatica pain, like I briefly discussed before, it's caused by a pinched nerve. Now, the sciatic is a nerve that goes from the leg down to your foot. It's formed by the nerves coming out of your spine. In other words, the lumbar nerves, you have lumbar 1, 2, 3, 4, and 5, and they call those nerve roots. These nerve roots come together, and each one specifically goes to different areas of your leg.
Okay.
For example, let's talk about sensory. In other words, pain. You feel pain. Mm-hmm. If you're going to feel pain, and if you have a herniated disc at L1, you're going to feel pain probably in your lower back, in the side of your hip, across maybe to the front a little bit. L2 might be into your groin, and still will mimic the L1. The further down you get, it catches all the nerves. Then L3 would be pain, as the one we said before, L1, 2 pain, plus it would go down to your anterior thigh into the knee, no further than the knee. If you get an L4-5 herniated disc, it goes into your calf and maybe ankle. If you get a 5S1 nerve root pinched by a herniated disc or a pinched nerve from bone spurs, it'll go down into your ankle and into your feet. Ooh. So pretty much I ask the patients, where's your pain? And they tell me, and I can figure it out based on that. Of course, the best thing to do is look at an MRI. So to answer your question, sciatica pain is any one of those 5 nerves being pinched by a herniated disc, by bone spurs. The hole where the nerve comes out of in the spine is called a neuroforamina. That hole is made up of different structures that can slowly grow. Herniated disc can go into that tunnel. Bone spurs from the arthritis can go into the tunnel. And when we have degenerative disc disease, the tunnel actually gets smaller because the roof and the floor get closer together. So this is a combination of just making it stenotic. And stenosis is the tightening of a canal, right? So any tightening of the canal of that nerve will put pressure on that nerve, of that canal, will put pressure on that nerve, causing you to have sciatica pain.
So now, is that the same thing, like when you say that you go in with a little incision and you separate the nerve so nothing's holding or nothing's hitting it? Is that the same thing you would do for sciatica? Like, what do you do to fix it? Is that the same thing?
Absolutely. The first thing I usually do is a person comes in with severe pain, and what most pain doctors do will give them an epidural injection.
Oof.
And there's different types of epidural injections. There's an intralaminar injections that, kind of old school. We used to do those blindly a million years ago. But today, it's all done on the precision X-ray, live X-ray, fluoroscopy. But
that's that crazy X-ray thing that you have in your office, right? The one that's like...
Yeah, the very expensive one.
That one. That thing I don't want to ever touch. Yes, okay.
So, like I said, you have 2 different types of epidurals. The intralaminar epidural, it might be okay for somebody who has spinal stenosis, central canal spinal stenosis, but not really. It just doesn't work. And be leery of or skeptical about a doctor giving you an intralaminar epidural. How do you know? If they're giving it to you dead center in the spine, that's probably an intralaminar epidural. Chances are it's not going to work. Because when you have foraminal stenosis, where the pinched nerve is the nerve coming out of the spine, which is not in the central canal, that epidural is going into the central canal. So it's not going to reach that nerve. So it might give you a little bit of relief for a day, maybe not even, or for a couple of hours. But they have the other type of epidural, which is much more efficient, which came out later. We've still been doing it for many years, but there's some pain docs that don't do it.
Why? Why would they put it dead center if you know?
Number one, they don't know.
Yeah.
Number 2, it's a little bit more difficult. Number 3, and I hate to say it, some of them work for spine surgeons. You know, I get upset when people say there are bad doctors out there, but there are.
Yeah.
And they're dishonest doctors. It's like there's dishonest butchers, there's dishonest accountings.
Right,
There's always can be somebody dishonest. And they you know, they fail. You know, and if anybody says, I'm going to give you a series of 3 epidurals, that went out 10 years ago. You don't do a series of 3 epidurals. An epidural, you do it. If it doesn't work, it's not going to work. And those chances are they're not going to work. So the transforaminal one, going back to what that is, we don't go in the spine, in the center of the spine. We go along the nerve that comes out of that neuroforamina, that tunnel that's compressed. Because the epidural space, it goes a little bit on the outside of that nerve and stops. It's a dead end. It's closed. So if you pop into the epidural space along that nerve, it's a hard concept to understand. I got to show it to you when you see me on a model. But you pop into the epidural space there, and imagine that it fills up the epidural space. Now, toward the center, it's tight. It's being kinked. Right? That's why from the center it's not going to go out. Because in the center, if you do it an epidural in the center, it goes up and down. It doesn't go over the nerve. But when you do it on the nerve, it fills up that pocket there of the epidural space. And like I said, distal to this, it's a dead end. It stops. You know? And then it fills up, builds up pressure, and boom, it pops through that stricture and into the center of the canal. So you're doing an intralaminar epidural in the center, and you're doing an epidural on the nerve, and that's what counts. That nerve's going to feel good. I'd say 80% of the people, you do that, and they're done. You were asking me about the procedure. Mm-hmm. Sometimes the herniated disc or the canal is so tight that even that's not going to work.
Well, is it fixable? So, like, if you have sciatica and they come to you, is it something that's fixable, or then do you always have sciatica?
I don't think I ever had it, especially within the last 10 years. I don't think I've had anybody I could not get rid of their sciatica pain from the cause.
Oh, really?
That caused very simply with a 4-millimeter incision endoscopically.
And just once? They just have to come to you once and get that done? Or
Well, no, we got to make the diagnosis. You know, a lot of people come in, they don't even have an MRI. So
no, I mean, like, once you do the epidural and you go in there, then that's it? Like, they don't have to
the epidural is done because the patient's in severe pain. They're desperate. They can't even walk. It's sciatic pain. Have you ever had sciatic pain? That is terrible pain. You can't walk because every time you walk, it shapes the nerve or stretches the nerve that's being pinched, and it hurts like hell. So I calm it down with the epidural. Even if I look at the MRI and I see that there's no way this person's going to survive with just an epidural, but the epidural will make them feel better. And then we could talk about when the person is calm, they're not so desperate. Right. And watch how some people are desperate. They say, I'm going to take care of this once and for all. They go to a major spine surgeon. They say, okay, we got to operate on it. And they do major spine surgery, and they don't need it. Okay. Because I go in there with that little incision. It takes me 20 minutes to 45 minutes, depending how severe it is, how many different types of problems. They might have a herniated disc, bone spurs, tightness, arthritis. Mm-hmm. I mean, it might be a little bit more work than normal. So, if somebody just has a herniated disc, I go in there 10, 15 minutes, I take it out.
Oh, wow.
Okay. And they're cured. You don't say cured. You don't say cured in pain management or spine surgery. If the doctor says, if a patient says, "Are you going to cure me, doctor?" We say, "Well, no, we don't guarantee anything."
Right.
I mean, that's a general answer. But if you have a herniated disc putting pressure on a nerve and I pull that out, you're cured. Now, you say, "Is that it? Done?"
Right.
Well, we do have an incidence. In other words, we have a chance that you can have a reherniation.
So that's when you were saying, like, if people don't take it easy and they start going,
you have to listen
craziness.
to the doctor's instructions.
That's true.
Right.
That's true. However, you could have a spontaneous reherniation. The patient comes in and says, I didn't do anything. I hardly did anything. And I was putting my socks on, and all of a sudden I felt something hit my nerve again, and now it hasn't gone away. I mean, even something like that can happen. Why? Because it happens. It's the way the way their disc is. We can, and let me tell you about the statistics. Overall, internationally, if it's major spine surgery or minimally invasive spine surgery, there's a 6% chance that you're going to re-herniate.
Oh, wow.
If you had
that's kind of low, a 6% chance.
Well, you think about 6% means every 100 people, 6 people are going to have it. So that's not real low. But now, if you go get major surgery and you re-herniate, I hate to say it, a lot of patients come to me. Now, this is based on what my patients say to me. He said, Doc, I went for surgery and I re-herniated, and the doctor doesn't want to operate on me anymore. He just doesn't want to see me anymore. He said, go to pain management. And I see the pre-MRI, I see the herniation, then I see the post-MRI, and they still have a herniation. Now, whether it's the same one or a new one, I see it. I go in there, I say, I'll take care of it. I go in there, make that 4-millimeter incision, endoscopically, take it out. Okay. And then it's gone.
Which you actually did for me, because I had full open back surgery.
Right.
Before I met the doc.
Right. You couldn't even walk.
I couldn't walk. And then it helped me for a very short time. And then the little area that they burrow away to allow for the hernia, to the herniated material to go, so the pressure is relieved off of the nerve. That fills up over time with scar tissue, and then you're back to square one. And so it's only a temporary fix in a lot of cases. And for me, certainly. Then he gave me his endoscopic discectomy. You pioneered that, right? You were one of the pioneers.
Yeah, I mean, it's been around for over 20 years, but they were, when they first came out, it was rudimentary scopes, rudimentary instruments. But when I started to come on board, it was still old school stuff. They weren't doing much. They were doing glorified percutaneous discectomy, going in the center of the disc and taking the center out and decompressing it from there. But I was one of the first guys, and there was probably maybe 4 or 5 of us throughout the world that actually started to venture outside of the center of the disc and actually going to what's pinching the nerve. I was just going to say we're getting so interesting here. We're probably mesmerizing people. Nobody's calling in, but we just got a high sign here that somebody's calling in. Hold on here. Okay, who is this? We have a caller?
Yes, good morning, doctor. Yes, this is John. I have a quick question about the topic today. How does one know if the difference between the sciatica issue and maybe throwing your back out?
Well, when you say throw the back out, what kind of pain is that? Why do you get that?
Well, kind of like, sort of mid to lower back area, and sometimes it could stretch down to your leg. But I just think it's one of those things where how do you really know the difference?
Well, that's a good question, because if it's going down your leg, that's almost guaranteed to be sciatica pain. You throw your back out, that's another layman term like sciatica is. Doc, I threw my back out. Then I ask them what kind of pain it is, like I just asked you. If they say, I got this big spasm, lower back, I can't move, it's hard for me to breathe, I put my hands on them, I feel a spasm, that's throwing your back out. And a friend of mine told me, he says, you're getting old when your back goes out more than you do.
That's funny.
But anyway, throw a little joke in there. But the point is, when you throw your back out, my definition is if you pull a muscle. For example, I had an older guy, he's probably 82 years old, he's a golfer. He didn't golf for a couple of years. He had his knee operated on, so finally back on the golf course, and he did 18 holes, and he comes back to me the next day. He couldn't even walk. He says, Doc, I took a swing around the 8th hole, and I pulled I threw my back out. And I felt he had a knot, felt like a golf ball in its center of his spine. So that we call that the overuse syndrome. He finished the 18 holes. That was the worst thing.
It's golf.
If he would have stopped right there and went home, put some ice on, he would have been okay. But he was leaning forward. He could barely move. So I do what they call, very simple, which most pain docs do, and physiatrists and even general practitioners, trigger point injections. You hit some local anesthetic in there, and it paralyzes that band of muscle, and then blood starts rushing in and heals it up, and they're good. But if you're getting pain down the leg, that's sciatica pain. Is that what's happening with you?
Yeah, I look on the internet too, and a lot of the sites that I come up with when I do my search is like different types of positioning and exercises and stuff like that. And I don't really know if that's really the most, effective thing, and that's why I wanted to get your take on that.
Well, the general rule is that somebody has sciatica pain, herniated disc, back pain. 80% of the people, it goes away on their own. And that's good. And all these things that you see online, conservative treatment, chiropractor treatment, physical therapy, these things help to a certain extent. But if there's no room in that, remember that tunnel that I was telling you about, the neuroforamen, if there's no room in there, no matter what you do, it's going to get worse. It's going to chafe that nerve and get worse and worse and worse. That's where I come in. After a few weeks, if it doesn't go away, you need an MRI. We got to look at what's causing it, and I take it away. That's what I do.
So is the treatment you're proposing with the injection something that could alleviate it quicker than going into these types of exercises and this and that I see on the internet?
Well, like I said, I'm always going to talk about what happened in the old days. If somebody comes in with severe sciatica pain, as far as I'm concerned, and if it's there for a while, like I said, it might go away on their own, but it's usually there. If they come to see me, it didn't happen 2 days ago. It's happened months ago or weeks ago. And if it doesn't go away within a couple of weeks, or at least a month, 6 weeks at the most, then it's not going to go away unless you get in a position where you feel no pain, and then the nerve will slowly heal up. But then you can't do anything. Your life is over until it heals up. But you're right. It gets rid of it faster. But the insurance companies today, they say, no, you have to do physical therapy. You got to do chiropractor treatment. You got to do all kinds of different stuff. You got to take NSAIDs, Motrin, Aleve. You got to take all of this stuff before they can approve you to do, certain insurance companies, not all of them, which I don't agree with, because if it's that bad and you're working it with physical therapy, it's just going to make it worse. But the ones that go, wax and wane and come and go, physical therapy might help you in the long run. But if you're the kind of guy that it goes out once a year, twice a year, and you know how to get rid of it in a few days, that's the process of somebody who has a bad back. You got to kind of learn to live with it. But if you don't want to live with something like that, I've had patients that come in and says, the same scenario a couple times a year. This happens, and I get an MRI, and one of those tunnels of neuroforaminas have a little herniated disc, some bone spurs, and when they overdo it, it swells up. I tell them, next time this happens, since it's been happening and it's your history, come in and we'll make the proper diagnosis, and I open up that canal a little bit in 15, 20 minutes endoscopically, and then it never comes back again.
Sounds good.
All right, John. Thank you for calling me. Hope I'll see you. Well, hopefully I don't have to. I hope I don't see you for your sake, but if you have any problem, come on in.
Thank you very much. I know where you're coming from. Thank you.
You're welcome, John. Bye-bye.
Actually, I have another question about that. What is the difference then if somebody goes to a chiropractor or if they come to you? Like, why would I go to a chiropractor? Why would I come to you in that scenario? What's the difference?
Well, one of the main reasons why people don't come to me is they don't know about me. They don't know that we're here to help them in that way. And that's one of the reasons why I'm doing this radio station. Mm-hmm. That's why I advertise. People say, other doctors say, I don't have to advertise. Why do you have to advertise? Well, the main reason I'm advertising, of course, it helps us, but it helps the people. I mean, look at all this wealth of information that we're giving out there to these people. Like John, he didn't know.
Right.
Right? Now he knows. Now he knows that if he wants to. And by the way, you don't have to go to your family doctor if you have all of these symptoms. You don't have to go to an orthopedic surgeon if you have all these symptoms. You come directly to the interventional pain physician. If this radio station's getting up north where you can't come down here, they have pain physicians up there. A lot of them know me. So if you need anything more, they can, or talk about me. If the epidurals don't work, don't go run into a surgeon. There's some surgeons that do what I do, and there are some surgeons that say they do what I do. They don't.
Right.
It's a marketing thing. Minimally invasive spine surgery with an incision that's 2 feet long.
What I found interesting was what you said earlier, how some doctors, they just give you a series of 3 shots, and it's just the old style of trying to take care of it. Now, you and I would have known each other for a while, and I didn't know until you said it today that the doctors I was with previously had me in that cycle.
Yeah.
And like I was just getting 3 shots, series of 3, and then I'd have to wait until my insurance allowed another series of 3, and then another. And but it really wasn't taking care of the situation at all.
Well, a little bit on the series of 3. If you have a pinched nerve and you give it injection, and I always give a little local anesthetic to numb the nerve, so it gives me a diagnosis. When I do it 20 minutes later, if I got the right level, which usually I do because I read the MRIs, pain's all gone. It's either 80% to 100% gone. They feel no more pain 20 minutes after the procedure. That's a diagnosis. So now we know the area. And if it comes right back within a week, why are you going to give another epidural injection? You're going to give another one, it's going to come back in a week. You give another one, you can do hundreds of them, it's going to come back in a week. If an epidural works, and this is people say, well, how long is this going to work, Doc? Well, you know what? The only answer to that question is the nerves hurt because they're inflamed. This is a very simple concept. Inflammation is pain, swelling, and redness. Anybody knows anything about inflammation, especially a medical student or doctors or nurses, it's inflammation is pain, swelling, and redness. We don't care about the redness because it's in the body, so it's swelling and pain. Now, when you give a shot with an anti-inflammatory, what is it going to do? Get rid of the pain. And it's going to get rid of the swelling. However, the swelling takes maybe 6 weeks to go down.
Right.
The pain within 12 to 48 hours, you're going to feel pretty good.
6 weeks to go down, really?
The swelling.
Wow.
The swelling. But you might, during that period of time, have no pain. So people have to understand that the nerve is now still swollen, and it might be getting kinked. It's still kinked, but slowly gets shrinking down, right? So that's why we tell them not to go crazy after the epidural. But what happens is when it starts to shrink down to normal size, and if that tunnel, that neural foramina, or that herniation is so big that no matter how much it shrinks, it's putting way too much pressure on it, it's going to come right back. So we don't know how long it's going to take for the epidural to wear off. That's another layman's.
Yeah.
Hey, Doc, how long is it going to take to wear off? Well, we don't know because unless they had one by another doctor and they said it took 6 weeks and then it came back. But then I don't trust anybody, call me a pessimist, but I only trust myself. So if that happened with another doctor, other doctors might not put the injections in where you're supposed to have it like I do. And I'm not bashing doctors. I just tell you my experience. And I have to do my own injection because I've had patients come back and say it only lasted a couple of weeks, and I do it, and it lasts 6 months to a year.
Yeah.
And they're asking me, how come yours? And I said on my first show, I said this. How come yours work and theirs didn't? And there's different reasons. I use different medication technique and skill. You have to be able to put that tip of that needle a millimeter from the nerve. Without going in the nerve. And I see somebody, I teach these guys how to do it, and I say this all the time. You're like 2 centimeters away. It ain't going to work.
And yet 2 centimeters away sounds like just so small, like a small little.
An inch and a half, 2 inches away.
Right.
I tell the doctors, I teach them how to do this, and they say, how's this? I've said this before on the radio. So how's this? Is this close enough? No. What do you mean, no? It's not close enough. You're way too far. It ain't going to work.
Right.
And they get closer. No, not good enough. And then they might. We're doing it on cadavers. We're not doing it on live.
Yeah,
cases.
right.
And when I teach, I don't think any patient will let the guy stick them 10
multiple
times.
Multiple times, yeah.
Right.
But after 10 times, I give up. They shouldn't be doing it.
Right.
But what do? This is what they do for a living. They're going to go out there. So nobody's there standing next to them saying, you're too far away. So they do their injections, and then the patients say it didn't work, and then they go to a surgeon. Surgeon say, well, this is good reason. Your epidurals didn't work. We need to do surgery on it. And you can't blame the surgeon for that.
Right.
Because the surgeon has to trust whoever's doing the epidurals. If they don't work, then he's got to do the surgery. He's got no choice. Even though it doesn't look like they need surgery, but you know what? You go to the wrong person, you might end up getting unnecessary surgery because the doctor didn't put the needle in the right spot.
So it's definitely the difference between what to do and how to do it.
Yeah. I mean, we all have this standard of care as far as how to make the diagnosis, what's the next protocol, what do you do next, what do you have to do, if this doesn't work, you go. I mean, it's standard stuff.
Yeah.
And, I've been doing this for over 20 years. And, board certified, specialty, we're super specialists. When you're doing something and you're in good shape and you're not senile and you're doing it for 20, 30 years, there's nobody better than that. You've been through it all. The more experience. When my grandfather retired as a physician, I said, I think it's a shame that you're retiring because you have so much knowledge. I mean, he graduated medical school in 1923. Right. Oh, wow. They didn't know that much. And I just started college in the 70s, mid 70s. I started college, and he was retiring. He was probably 80 years old or something.
Oh, wow.
And he was retiring. I said, "What are you retiring for?" He goes, I'm getting old.
Wants to play golf.
But no, he didn't play golf. No, nobody really plays golf in my family. It's not dangerous
They
enough.
race cars.
Yeah, we race cars, stuff like that. But anyway, because to me it was a concept I couldn't understand, because you're a walking medical encyclopedia, and you can't learn this with books. So my point is, I've modified my way of treating patients the Gabe Jasper way, the Dr. Jasper way, and it works. Sometimes I'm outside the box. Insurance companies don't like it, and sometimes they don't approve it. But I know it works, based on my, my
experience.
History, experience, yeah.
You also just brought up another good point. And again, me sitting here as a layman, not really knowing obviously not knowing near what you know. Is there a difference? So if I'm a listener and I don't know, maybe I don't have the best insurance, is there a difference between what a chiropractor would take or what a doctor would take and what you would take, or is it just all the same thing?
What do you mean, as far as insurance?
Yeah, as far as insurance. Is it the same thing? Because I know sometimes...
No, it's the same thing. I never really answered your question. I answered it a little bit about the chiropractor. People know chiropractors. Mm-hmm. Chiropractors are all over the place.
Right.
And you get a good chiropractor, you got a good chiropractor. Mm-hmm. You have some chiropractors that think they can cure cancer with manipulation of the spine. I don't think they're good chiropractors. But I have some chiropractors that send me patients. I send them patients, some friends of mine, that they're damn good chiropractors. I mean, they help patients. They align the spine, especially with the arthritis and the spondylosis, with the facet joints, the low back pain with the arthritis. They realign all the joints in the spine, and you might need more than one manipulation, but they help you.
Right.
So I'm not one of those MDs that are against chiropractors. You got some good chiropractors out there. I mean, you provide, they got to do an X-ray, do an MRI. It's nice when I get a patient from a chiropractor that actually has an MRI before they get there. They know what's going on. They know what the patient has, and they know they can't help them anymore, and then they send it to me, and I take care of them.
So when it gets to the point where they think that they can't help them anymore, is it because of the incision angle of it? Is that why a chiropractor wouldn't be working anymore for somebody?
What do you mean the incision?
Well, if you're going to do something where you're helping somebody by doing one of those incisions, or is that a reason why that a chiropractor wouldn't work? So
the chiropractor?
No. The chiropractors, listen. The chiropractor.
How do you know when you get to the end of the road with a chiropractor? I guess is my question.
Well, the chiropractor should know that, and there's no end of the road with chiropractic, because if you got a big herniated disc and it's putting pressure on the nerve, and a chiropractor sometimes can manipulate them and line up the spine where it opens up that neuroforamina, that tunnel where the nerve comes out, and separates the herniation from the nerve, mm-hmm. and they do good for a while, and that gives the nerve a chance to heal up and shrink down, like I said. Once it shrinks down, and if it goes back out of line, the nerve now is small, and it doesn't hit the nerve unless you overdo it.
Right.
And if I go in, and usually when a person has a bad back, bad neck, when I get rid of their pain, they still might need constant adjustments to avoid the pain from coming back, or just overall good health of the spine. I mean, they're good. They're good for good health of the spine. They know the anatomy, and they know a lot of them do their own physical therapy, and they teach you what to do and what mm-hmm. not to do, and how to move, how to lift and bend. They're if there's any chiropractors out there listening, I invite you to come to my office and start a relationship with me. I mean. Come and look and see my facility, see my surgery center. And there's a lot of chiropractors out there also that don't know what I do.
Right.
They'll send them to surgeons. Why? Because they don't know that I could take care of it without any major surgery.
What about now? Can we talk about your facility? Like I don't think people really know what you've got. You have your you have your exam rooms and stuff on one end, but you're the full package.
Well, right now I'm a solo practitioner, which is probably something you used to hear in the Stone Ages. We're a dying breed. I have a tremendous overhead. I have probably close to 20 employees, secretaries, billers, office managers, CFOs, CEOs, like I said, the nurses and x-ray technicians. And it goes on and on and on. And I'm still bare-boned. Everybody's working their butts off. But it's about a 16,000 square foot facility. And it's divided into two major areas. I have a surgery center, which is state licensed, Medicare licensed, which means it has a federal license, which means that it's very stringent rules and regulations as far as even the light switches have to be a certain height from the floor.
Oh, wow.
Oh, wow.
The lighting has to be special lighting. The floors have to be special floors. In order to get what they call AAAHC approved, Medicare approved, and they're constantly they give us surprise attacks where they come in and they send in like somebody with infectious disease. One day will come in and make sure that everybody does everything properly. There's a certain way to wash your hands before you do a procedure. You have to change your gloves all the time. You got to wear the hats. This is a facility I have. It's not just a procedure room in my office, which is not controlled. It's controlled by the states. It's kind of a pain in the ass, but it is. But it keeps us safe. It keeps us on our toes. But I do have a procedure room in my office, to do certain procedures. If a person comes in severe pain, I do trigger point injections in there. I do some knee joints, elbow, shoulder joints. I do a lot of joints, and I've been doing a lot of PRP, platelet-rich plasma, and stem cells. That's another topic that we kind of miss it every once in a while. But so usually a patient comes in, they make the appointment, they come in, the nurse sees them, they fill out the papers, the nurse sees them. When the nurse sees them, the nurse presents the patient to me. I come in and I introduce myself, and I give them do a basic physical examination. If I need to do it more in depth, like a neurological examination, I do. But the most important thing is they have the MRI with them.
What if they don't? Like, what if somebody wants to see you and they don't have an MRI?
Well, if they don't have an MRI and they make then they need to come and see me to do an evaluation in order for the insurance companies. Some insurance companies won't approve it unless you see the doctor.
Oh, okay.
But if you're already seeing a chiropractor and you have an appointment with the chiropractor before you come and see me, let's say, for example, or your general practitioner, they can send you for an MRI. They just have to know why. They can, the chiropractors can call me, the general practitioners. I have an ongoing communication with all the family physicians of my patients. I call them up. I send them all the reports. Any doctor refers me patients. I do an evaluation. I send them all the reports and giving them updates. Sometimes I call them and let them know what's going on if they want me to.
Gotcha.
I think it's important to say, though, that you also, you really you spend your time with the patient. You get to know them. You find out, you develop a relationship with them. You really give them your time when they come in to see you.
I'm a pretty social person. Obviously, I don't. This is what I'm talking about here on the radios. We kind of wing it every week because.
Yes, you do. You wing it every week.
That's right. It's all, what do they call it, ab-lib?
Yeah.
I don't know if I've said that. Ad-lib, yeah.
I might call it something else, but that's a whole other topic.
Well, you know what? That's why you're talking, because we were running out of things to say, and all of a sudden you're asking me questions on the break. There, you got to ask. Now all of a sudden we're like, we got the Three Stooges here now.
Yeah.
Oh, can I be Larry?
You got the hair for it.
Oh, nice.
Yeah, you got the hair.
Great.
It's only good for the radio. No, I'm just kidding.
Hey. I don't like you two now.
Hey, we got him laughing in the other room. Yeah, but what was I saying?
See, now I don't know, and I'm not going to interject
The
anymore.
patient, spending time with the patient.
Oh, yeah. So I'm a little bit too personable sometimes with the patients as far as I like to get to know them.
He promises he won't make fun of your hair if you come in.
I like to talk to them. I like to, and believe it or not, I did it because that's my personality. But I've learned over the years that by learning the personality of the patient, you can learn what their pain thresholds are.
Sure.
You got somebody that what they call a stoic person, where you could probably stab them in the leg with a knife, and they're like, "Ooh, that hurts." Another person, the elbow, and they're like screaming.
Yeah.
So you get to know, what you're dealing with. I have a patient with a very high pain threshold, and you got to look through that and they've been to other doctors, and other doctors see him and say, "This guy's got no pain," And we got some stuff in the MRI, but I really don't complain much because people don't like to complain sometimes.
Yeah.
But when you talk to them, then you start to ask them what they do. Well, I used to do this, I can't do this. So you figure out that they got a high pain threshold, and then when when you take care of them, they come back. They're very grateful because you're the first one to fix them because nobody realized that they really had pain.
Right.
Or you have some people that really have nothing wrong with them and they're in severe pain. Everything hurts. That's another story. A lot of these people need therapy. They need, psychological therapy. Their pain thresholds are so low. In other words, for very little stimulation, they perceive pain a lot higher. And a lot of times that's because, and we discussed this before, because they have a negative affect. They're depressed or angry. Yeah. They have anxiety. So they need therapy and they need to get that taken care of. And I could see that, but I'm not a psychiatrist, but I've been trained. And you don't really need to be trained to see if somebody's not really 100% up there,
Right.
And when you see somebody like that, you change your philosophy where, I got a big ego. I know what's wrong with these patients. I go in there and I fix it. I give them an injection. I expect to have 100% pain free. And they say, "Oh, I'm 10% pain free." 10%. I just numb that nerve so much that you shouldn't have any pain. I don't tell them that.
Sure.
But I'm a little set back. Whereas other people who have normal affects are happy people. And they're not angry. They don't have anxiety. They're not depressed. And you numb that same nerve with the same pathology, the same herniated disc. And you go there 20 minutes later, and they're like, "I am 100% pain-free, thanks, doc." Because they don't have anything in their brain causing them. That you say, they always say, "What am I? I'm not crazy. I'm not making this up." No. What happens is, when you're depressed, you have negative affect, your brain perceives pain a lot more. It's not your fault. The only thing is your fault is you haven't gotten taken care of. You haven't been to a therapist. I mean, therapists, it's not like they have to reinvent the wheel. They're fully trained in talking to people that are in pain. It's almost like a marriage counselor. You go see a marriage counselor or couple counselor.
Right.
They know they see so many and they've been trained. They know when two couples are arguing and they're talking about their differences, you think it's the first time this counselor heard this? No.
Right.
So it's the same thing when you have pain. You go in there, "Doc, I got this," or whatever they know how to answer it. And then I got patients that finally come back and they say, "I feel better." I remember the first time that I didn't believe that this was actually true. I had a patient maybe 15, 20 years ago who, she was young. She was a little crazy as far as, she was all over the place. She didn't make much sense.
Okay.
I couldn't make the diagnosis. I'm not a psychiatrist, but I'm sure my brother's a psychiatrist. If he would have talked to her for 2 minutes, he would have known, given her a diagnosis.
Right.
Right. And I couldn't convince her to go see a therapist. And she kept having neck pain. She had a couple things in her neck. I took care of it. Had a little back pain too. Had a lot of, every pain she had was a lot, but not that much pathology in the MRI. And I treated it. She kept coming by, "I need another shot. Finally, I said, this is dangerous for the patient, and it's dangerous for me. I really don't see
why you're doing it.
Nothing's working. And then I tried to explain to her about getting therapy because you need to work on that at the same time. She says, "I'm not crazy," and she left. I did not see her. She left. She went to another doctor. She finally came back about a year later with a big smile on her face. She didn't have no more pain. I said, well, you found another doctor that got rid of your pain? She goes, no. After 6 months, I listened to you, and I said, well, maybe he's right. And I saw a therapist. And then they sent me to a psychiatrist. He goes, Doc, I haven't done any more shots.
Oh, wow.
I have no more pain. And that proved not only to her, but it proved it to me because I was, a younger physician, not as much experience. And that's when it consolidated the fact that this really works. Therapy, you got, when I was trained, nobody was able to see the pain doctor unless they saw a therapist. And that was at UMDNJ in Newark. The pain doctor there that taught us, the director of pain, he says, always send them for therapy at the same time. I said, well, some people don't need it. No, everybody needs to be evaluated because you don't know because you're not trained in it.
Oh, interesting.
But you can't do that. Insurance companies won't pay for that anymore.
Yeah.
That's a shame that insurance.
That's called a multidisciplinary. Oh, look what time it is. It's we got 2 minutes to close up this deal.
All right.
Yeah. Unbelievable. All right. Well, we didn't take too many breaks today. We didn't have too many calls. John, thanks for calling in. We should send John a gift certificate for something.
I'll see if we have windmill left. We might.
Maybe windmill.
No. You like hot dogs, John?
Yeah.
Everybody likes hot dogs.
Sure.
But let me just go over,
Gabriele
Jasper, MD, Jasper Spine Institute. That you can, or Jasper MD. You can look me up. Most of my procedures are on YouTube. I'm on Facebook at Jasper Spine Institute, and I'm located in Bricktown, 74 Brick Boulevard, 732-262-0700, right across the street from Burlington Coat Factory, right behind the new Roy Rogers. Give me a call. I'll take care of you. By the way, if you have an MRI report, you could send it to me free of charge. It's a courtesy that I'll give, and I'll read it, and I'll call you up, or my nurse will call you up, tell you if we can help you. Thank you very much. Have a great weekend.
Thank you for listening to Painless with Dr. Gabriele Jasper of the Jasper Spine Institute. For more information about the services he provides, go to jaspermd.com. Be sure to listen to Painless every Saturday from 10 a.m. to 11 a.m. on Beach Radio 1160 and 1310 and mybeachradio.com.